We've now started recording, Alison, and over to you.
So welcome everybody, and hello to the annual general meeting in common for the 6 CCGs in Staffordshire and Stoke-on-Trent. My name's Alison Bradley. I'm the chair of North Staffordshire CCG Clinical Commissioning Group and a GP in the Staffordshire Moorlands. And I'm also the Integrated Care System Board representative for the 6 CCGs. So this is our second virtual AGM event, but our first hosted in Teams meeting. So we hope you will enjoy the ability to interact both with me and the other speakers. So today's meeting is being recorded and will be published on our website following the end of the event. So I'm just going to run through some meeting etiquette. So throughout the main section of the presentations, if you could please keep your cameras turned off unless you are presenting or asking a question, and remain muted until prompted. So this will allow our British Sign Language interpreters to make sure they're on display throughout the meeting. When we reach the Q&A portion of the event, if you could please raise your hand in the Teams function if you would like to ask a question, and you'll be addressed in order. Could I have the next slide, please? So before we start, I'd like to take a little time just to reflect on COVID-19. So this year has been tough for all of us, and none of us could have imagined what it would be like to live through a global pandemic. And my heart goes out to all of those who have lost their lives or been affected by COVID-19. Next slide, please. So there's the agenda's now on the screen, and the agenda covers what we're going to look at today, and we've decided we're going to look back over the performance and achievements and the financial summary for 2021. And we'd also like to have a focus on the CCG's response to COVID-19, and then look forward to how we're becoming part of the integrated care system. So, next slide, please. So I'd like to start with an overview of who we are. So we are 6 clinical commissioning groups working across 3 localities in the north, the southeast and the southwest of Staffordshire. And we commission, which means planning and buying healthcare services for our population, which is just over 1.162 million. So as part of our health and care system, we have 147 general practices, which are part of 25 primary care networks, which you'll probably have heard being addressed to as PCNs. So there are many factors which we need to consider when commissioning care for our population, and these include our ageing population, the fact that people's health varies depending on different levels of poverty, deprivation and health inequalities. And we also have a diverse population with 8.8% of people in Staffordshire and 17.8% in Stoke-on-Trent identifying themselves as non-white British. We also have to consider long-term conditions, and a number of people with long-term conditions is increasing, with now more than half the over 65s with 2 or more long-term conditions, including conditions such as diabetes, heart disease, strokes, and obesity is also significantly higher in Staffordshire than the national average. We also see in Staffordshire, in particular Stoke-on-Trent, a lower life expectancy than in other parts of the country. And more people in Staffordshire age of 75 and over die of cancer than in the rest of the country. Sadly, throughout the COVID-19 pandemic, we've also seen that deprived and ethnic minority communities are more at risk of exposure to COVID-19 and also have poorer outcomes due to existing poor health and adverse lifestyle effects. Next slide, please. So I'd now just like to look at the journey of the journey that we have taken as the 6 CCGs. So through the Staffordshire and Stoke-on-Trent integrated care system, we are reforming how we work across partner organisations to meet the needs of the whole population, with a commitment to empowering decisions made at the local level through 3 place-based partnerships, PBPs, which is quite difficult to say. There are also already strong relationships with the 2 upper tier local authorities of Staffordshire County Council and Stoke-on-Trent City Council, which have strengthened during our collective response to COVID-19. And we want to embed and further develop effective system working arrangements through our transition to the integrated care partnerships by April 2022. Next slide, please. So this slide shows our vision, which has been developed as an integrated care system board, with all partners working through a series of development sessions to redefine who we are and set ambitious priorities for the future. Through this, all partners have committed to a single purpose statement, working with you to make Staffordshire and Stoke-on-Trent the healthiest place to live and work, and also 4 core priorities for 21-22. Demonstrating that we are one system, we have strong clinical and professional leadership to develop these priorities, and each of these priorities has a senior responsible officer, including chief executives from our local authorities and the NHS, as well as a clinical lead. Next slide, please. So this is our provisional timeline as we work towards becoming an integrated care system in April 2022. We've got a significant year ahead of us of transition. So Together We're Better, the partnership of the NHS, councils, Health Watch and voluntary sector organisations in Staffordshire and Stoke-on-Trent became an integrated care system on the 1st of April 2021. So there will now be much more greater focus on working together to manage resources, performance and quality to change the way health and care is delivered for the better. So by April 2022, the ICS will become a statutory body subject to legislation, and an integrated care board will replace the 6 CCGs. The 6 CCGs will be abolished, and instead the integrated care board will plan and purchase services for the whole system and make sure that patients' views are also considered. We hope that our legacy will be a few barriers between organisations and services, and more services will be available to our local communities. So I'd now like to hand over to Marcus Warnes, our Accountable Officer for the 6 Staffordshire and Stoke-on-Trent CCGs, for him to update on our achievements and performance over the past 12 months.
Thank you, Alison, and thanks for the opportunity to talk through, I think, what's been a really successful year, if probably the most challenging, difficult year that any of us working the NHS has probably ever had to face. Could I have the next slide, please? So the purpose of the annual general meeting is to present our annual reports and annual accounts for last year. Now, whilst the 6 CCGs share 1 accountable officer, 1 executive team, 1 management team, we have our governing body meetings and our committee meetings in common, and indeed we're having a single annual general meeting. We are still 6 separate statutory organisations, so we have 6 sets of accounts. The accounts are pretty weighty documents, which you may not necessarily want to wade through all 6 of them. So we do have an annual summary document, and we've also got some summary videos on our CCG YouTube channel, which will give you a flavour of the headlines of the contents of the annual reports. Next slide, please. So as I said, last year was probably the most difficult year I've ever faced in the NHS, and my career goes back about 31 years. But we have achieved a lot, and it's amazing in the face of a crisis, probably the worst crisis any of it as in the NHS have ever faced, and I hope ever will face. And it is amazing just how much we have achieved when we come together as a system, put our organisational imperatives to one side and do the right thing for our patients, our population. So a few things I'm just going to pull out and just very briefly talk through. In terms of our commissioning directorate, a huge amount of work's been done on people with learning disabilities and autism. This is a really vulnerable group of people that sometimes it feels like a sort of in the background and needed to be a much higher priority. The NHS England were very keen that pre-pandemic and during the pandemic that we very much put them in the forefront of our planning and our system response. And we do know that people with disabilities, certainly in the first 6 months of the pandemic, were disproportionately impacted in terms of illness and death. So they suffered very badly at the hands of COVID-19. So we've done a lot of work around learning disabilities last year around a 3-year roadmap to improve services and access. We have an early adopter site for our children and young people to access. We now have a learning disabilities and autism programme board, which brings together all key service providers with service users into one place to plan strategically how do we need to meet the needs of our population with learning disabilities and autism. And another real area I'm really proud of is our Transforming Care programme, which started before the pandemic, but we were very keen to lock in the successes of that programme during the pandemic, so we didn't lose the tremendous advances we've made in terms of getting people with learning disabilities out of independent hospitals and back home into a supported setting, and that we achieved our targets for getting people home. Last year, the service was delivered by the CCGs and working with Combined Healthcare supported by the Midlands Partnership Foundation Trust. We've now transferred that service across to them this year. So they're actually working directly with service users to ensure that we can expedite the discharge from hospital and also provide alternatives to an admission to hospital. I'm pleased to say we met our target last year, and we're very much on track to meet our target again for this year. Another area that served us really, really well during the pandemic is our Community Rapid Intervention Service. Now, this is effectively an integrated front door service. So for people who go to the emergency department and potentially would otherwise be admitted, it's actually about identifying a more suitable alternative. So rather than being rushed to hospital in an ambulance, we have a 2-hour response from a community service that can go and visit them at home, provide the requisite care and keep them out of hospital unless they absolutely need to go there. That service is led by the University Hospitals of North Midlands, supported by the Midlands Partnership Foundation Trust, and our local authorities also work very, very closely with that service. And this year we're beginning to integrate the full service as well with the CRIS service to ensure we have a very comprehensive health and care service to meet the needs of our population who otherwise would potentially enter ED, the emergency department, and be admitted to hospital. That's been a huge success, and it's what we're also doing now is with the Ambulance Trust for our category 3 and 4 patients, rather than going to hospital, they're also being diverted into the CRIS service. So it's become a real way of us actually managing the front door of hospital and ensuring that people get what they need rather than waiting for a long time in ED. Linked to that is the 111 First service, which went live in December 2020. And I'm really proud to say that we were one of the areas that went first. We were an early adopter. And that's essentially about making appointments for people in emergency departments, in walk-in centres and minor injuries units. So rather than turning up and waiting through 111 first, they get triaged into the most appropriate service to meet their needs. That's taken some of the pressure off our emergency departments and also ensure that people get what they need rather than having to wait a long time for that. It also has access to our same-day emergency care pathways, which again is really, really helpful for them, but also, for instance, GPs who know where to refer those patients. I'm going to talk a bit more about the long COVID programme. I have a slide on that, so I'll leave that one for now. But again, our response to long COVID is, again, it's been something else I'm really, really proud of in terms of those people really, really badly affected in many cases by COVID, having a rehabilitation service that will enable them to get back on their feet and back to some semblance of normality. But more of that in a moment. From a governance and communications perspective, not only is the last 18 months been challenging for me, for my executive directors, for our clinicians, for our GPs and service providers, our CCG staff have also really stepped up to the mark and under huge pressure have performed exceptionally well. That has an impact both in terms of the physical and mental health, and what I've been very keen to ensure is that we have the right health and wellbeing support to all of our staff, so that we can help them to manage work-related pressures, which often eat into the evenings and the weekends. They do have some work-life balance, and we spread the load amongst the whole of the team. One of the things I did in March of last year, March, I think it was about the 17th of March 2020, when the Prime Minister made the announcement around our first lockdown, we sent everyone home literally overnight. They had a laptop, the latest version of Microsoft Teams and Windows, and they had mobile phones, and we bought them desks and chairs. We gave them what they needed to be able to work from home. And on the back of that, we developed what we called our Agile Framework. So you've probably seen in the media, lots of companies deciding, do we ask people to come back to the office? Do they continue to work from home? Well, we've already done that. And we had those conversations with all of our staff last year. And 95% of our staff told us that they wanted to spend no more than 0 to 2 days a week when it was safe to do so, working in office, and the rest of the time from home. So we've talked to our staff, we've listened to them, we've put in place an Agile Framework which has improved morale. People feel safer, cared for and listened to, and I think that's also been a huge success. Staffordshire and Stoke-on-Trent is a big place, and what we don't really want is people driving all over Staffordshire and Stoke, leaving home early, getting home late, increasing our carbon footprint through the miles that they travel when they don't really need to. So using new technology and the support we've put in place, people can now work from home, much as we're doing at the moment, use Teams for meetings, and only really sort of engage and meet with people when it adds value and they really need to do so. And also during the pandemic, I think communication across the CCGs and with our system partners has never been better. I always found it quite difficult having 3 offices that I needed to drive around, one in Stoke, one in Stafford, one in Burton. We have lots of our GP practices out there. Trying to work your way around the system and meet with people was incredibly difficult. With the magic of Teams, being able to have weekly webinars with our staff, with our GPs, meeting with system partners, we've probably been able to communicate better than we've ever done. And my staff tell me consistently that they probably know more now about what's going on than they did before the pandemic. So communication, particularly during a times of crisis when people need to understand and know what's going on and what that means for them, has been really important. And I think thank you to our comms and engagement team as well, who've worked with us to put in place a really, really slick communication plan, which means that people know what's going on, they know who to access when they've got an issue, and they feel safe and supported. Next slide, please. We often say things like, quality is our #1 priority, and the safety of our patients and service users is the #1 priority. And I think it always has been the case. And I think during the last 18 months, that's particularly been the case. And huge credit to our nursing and quality team working with other nurses and quality leaders across the wider system. Very early on in the pandemic, we put in place a range of measures designed to keep people safe and supported. We were asked to ensure that all of our care homes had infection prevention control measures in place, and all their staff were trained. Heather Johnston, who we'll hear from later, who's my Director of Nursing Quality, worked with system partners to ensure that was in place. In a matter of weeks, we had 100% coverage, and one of only 2 systems in the region. There are 11 systems in our region. We're able to deliver 100% coverage within the required timescales. And this is to ensure that the people who were impacted the worst during the beginnings of the pandemic, people living and working in care homes, were protected. And it's been some time now, but since we've had any significant number of deaths or outbreaks in our care homes, and a lot of that is testament to the work that Heather and her team did earlier in the pandemic. We've also been very cognizant of the fact we have a lot of clinicians working in some working clinical, many working in managerial roles in the CCG. And what we did very early on is identify staff, clinical staff who could return to frontline working, whether it be in the emergency departments, in critical care, staffing our testing centres that we put up very, very quickly early in the pandemic, working with our mental health providers, going back to general practice. So able to actually provide that clinical frontline support to ensure that we can maintain quality throughout the pandemic. And then finally, our learning, excuse me, our learning disability mortality reviews, the LEADER programme. A lot of that was paused pre-COVID. We had a backlog of cases to manage. And again, the nursing quality team cleared that by the December 2020 national deadline. So again, a huge piece of work, required a lot of coordination across the system. I think we've actually done really, really well on that as well. Next slide, please. The strategy and transformation team also played a key role. Now, this often can be seen as sort of a bit of a back office function, but they stepped forward and established very early on in the pandemic our incident coordination centre, which actually on behalf of the whole system helped us to manage the major incident in terms of our response, establishing cells to look at things like care homes, end-of-life care, workforce and operations. So played an absolutely key role stepping out of the day jobs and actually working on putting in place that incident coordination response. They've also played an absolute key role in terms of data analysis and modelling. What do we need to do to manage the pandemic and also continue to deliver our business as usual functions. So very, very key coordination role, as well as giving me and other system leaders the information that they needed to plan the next few weeks and months as we worked through the pandemic last year. They've also played a key role in terms of our restoration and recovery plans, in terms of how do we stand services up again when it's safe to do so. We did a lot of that work last summer, which was paused again as we went into winter and we had our latest wave. But again, it puts us in a good place in terms of our restoration and recovery process that we're working through now, and we'll continue to do so as we hopefully navigate our way out of the pandemic. And also in terms of our emergency preparedness, resilience and response, our EPRR system response. I am the accountable emergency officer for the CCGs, and we've very much coordinated across the system our EPRR response, working with the local resilience forum and system partners to ensure that our overall response was well managed, but also in terms of, for instance, that staff were redeployed into frontline or back office functions that would enable us again to manage our response to the pandemic. Next slide, please. So this is a fairly busy slide, but I think it's a really important one, and there's quite a few things on here I just wanted to spend a moment talking about. We talk a lot about the parity of esteem of mental health, and let's face it, the last 18 months has shown just how important access to and having high quality mental health services is, not just because of the stress and trauma that people have been through during the pandemic, but because our mental health is just as important as our physical health. So we have invested an additional £15 million in mental health services over the last year, and we have also delivered last year and will again do so this year our mental health investment standard commitments, which is around year on year increasing our spend on mental health, and we've invested more than we need to in mental health because it's important. UH&M, University Hospital of North Midlands, their major trauma centres, one of the best in the country, best performing in the country. And again, our major trauma network is seen as an exemplar both regionally and nationally. It seems like a relatively small amount of money, but another £200,000 funding to tackle health inequalities. And there's a huge agenda, as you heard from Alison before, through the integrated care system to really raise the profile of the inequalities that have been laid bare during the pandemic to ensure that we actually, to use the government terminology, do more levelling up. I can't take credit for this, nor can the CCGs, but £335 million worth of government investment in business and communities. We've been working, supporting our local authorities and our MPs to ensure that we do actually attract the investment that we need in our system, and that's a huge success and a huge credit to them in terms of the attraction of that investment into our system. As the NHS moves towards net zero by 2050, looking at how we heat our homes is really important. As you'll see on there, the geothermal district heating networks, which based on where the gas prices are going at the moment, finding alternative ways, more green ways of heating our homes, more environmentally friendly ways of heating our homes is really, really important. So a real success story there. Young people and our workforce are really, really important. So £62 million worth of investment in skills to support our workforce. Workforce is probably certainly the NHS's, if not the public sector's biggest challenge at the moment. And actually having a pipeline of young people who want to aspire to careers in health and care services across Staffordshire and Stoke-on-Trent is really important. I know that's something we, the local authorities in the education sector, are working very closely on. Also developing a pipeline of leaders, 89 leaders going through our Stepping Up leadership programme, ensuring that the next generation of leaders are being trained, supported and getting the experience they need to step into our shoes. All 6 CCGs are rated green for the work we're doing on patient and public involvement and equality, something I'm really proud of, because actually we do say quite a lot we want to put the patient at the centre of everything we do, and I think we're making good progress on that in a number of areas. The intelligent fixed payment system, the way that we actually manage the Staffordshire and Stoke-on-Trent pound, we're spending that once between all system partners rather than arguing around who gets the money, who pays and who bears the burden of the deficit. The work we've done on that in 2019-20, Paul served as well in 2021. You'll hear more about that from Paul Brown, our finance director, later. The vaccination programme locally and nationally has been a huge success. And we also now have one integrated care record so that people can access their health information in one place, and also that anonymised data can be used to plan services for the future to meet the needs of our population in the future. And again, Dr. Paddy Hannigan will be talking about that later. Next slide, please. I think I'm back. Am I back? I think you lost me for a moment there.
Yeah, you're back.
Am I back? Yeah, thank you. Nearly finished. So in terms of our long COVID clinic, I talked about long COVID a moment ago. We've got 3 main pathways into the long COVID clinic, which has been a real, I think, a real success for us in our system, and has been held up regionally and nationally as a model of best practice. People who've never been to hospital with their acute illness can be managed independently in the community. People who have gone to hospital, perhaps have been more ill, can access the service, as well as people who have left the integrated, the intensive care unit or the high dependency unit with COVID-19. So around about 10% of people have had COVID will have lasting symptoms. Of that 10%, about 2 to 5% will have long COVID, and will have some fairly serious things wrong with them that need attending to in the long term. So the long COVID clinic is very much about providing integrated care for them. It's actually delivered by Midlands Partnership Foundation Trust, and is very much a collaboration across the clinical community. Next slide, please. General practice access is something that people have been concerned about as we come out of the pandemic. I think it's important to say that general practice never closed for business. It was open all the way through the pandemic. The way that people access general practice changed and had to, as we had to keep people safe, and face-to-face appointments didn't happen unless they were absolutely necessary. People were still able to access the care they needed remotely. It's 92% of all contacts with the NHS are with general practice. That's the bit of the NHS people see most often, and it's important that people feel they can get the care that they need from general practice. So there's a huge amount of work going on around managing the backlog of patients who perhaps didn't access general practice, didn't feel safe to do so during the pandemic, people with long-term conditions, people who are outstanding health checks and reviews. So there's been a big surge in demand recently that general practice is working to meet, and we do have a general practice access plan that will help people to access the services they need when they need them. There's also maybe a lack of awareness around the variety of services that general practice offers. You don't always have to see a GP, and a lot of work during the pandemic was triaging people into the most appropriate service to see the healthcare professional that was probably best placed to meet their needs, which could be a nurse, could be an allied health professional, it could be a pharmacist. So general practice access remains one of the areas that we're really focusing on, and will continue to do so as we come out of the pandemic. I think a final comment around general practice is the vaccination programme, of which nearly 3/4 of all jabs have been delivered by GPs working in primary care networks in local vaccination services. That's been above and beyond the business as usual general practice. That's often being delivered at the weekends as well. So GPs working outside of their contracted hours to deliver the vaccination programme. So that hasn't impacted on the availability of appointments that people need for other things. Next slide, please. So again, I won't go through this because I do need to hand over to Paul in a moment, but we do have a plan looking at things like our access improvement programme, working with our practices to really understand the issues they've got in terms of opening up fully again, looking at, I think we've got another 137 telephone lines have gone into general practice to enable to help meet the demand of, I think we've got about a 30% increase in calls this year compared to this time last year. And also working with organisations like Healthwatch, who help us to understand what our practice population think about the services we're providing and how we can improve them. Next one, please. And then finally, restoration recovery I talked about earlier. Our focus really at the moment is on recovering our waiting list position. We had no one waiting more than a year for a planned care procedure at any of our providers. We have thousands waiting now, which is very similar to other parts of the country. A lot of work on cancer services, making sure that people get timely access to diagnostics and then treatments who have cancer. As I said, working very closely with general practice around improving general practice access. Access to planned care to outpatient appointments, which many of those have been on hold during the pandemic, ensuring that outpatient clinics and other planned care procedures are back on track and online to be referred into, and also supporting the urgent care system. COVID's becoming less of an issue for urgent care, but there's lots of other urgent conditions that people need to be able to access services to address. So a huge amount of work going on around restoration recovery, and as we've navigated our way out of the pandemic, increasing that's a priority for us, and we'll be spending more and more time on that. So I think that was my last slide. So next slide, please. So thank you for listening, and clearly an opportunity to ask questions about any of that at the end, but I'll hand over to Paul Brown now, who's our Chief Financial Officer.
Okay, thanks Marcus. Good afternoon, everybody. Yeah, this first slide shows and highlights that where we've spent our money, and very, very pleased to report that we've had an extremely good year, and we've met all of our targets. As you can see here, we spend about £2 billion. We spend about £2 billion in the financial year. The blue slice to the right represents the spend on acute services, so that's about half of what we spend. And then the other half is spread over 5 key areas. So mental health, community services, continuing healthcare, prescribing and primary care, then a few other bits and bobs beyond that. This next slide confirms that we had a very successful year, as I said, and you can see here the numbers in red are less than the numbers in black, which is good. Means that we spent a bit less than we were allocated, to the tune of 12 and a bit million, which is less than half of 1% away from the target. So we did well, I think, to spend the money on services, and we did obviously very well not to spend more than we were given. And at this point, I'd just like to pay tribute to the management team, because these things do not just happen, they happen through huge amounts of really hard work by a lot of people. So we not only delivered the successes that Marcus has outlined, but we did so within the allocations that we were given for the first time for quite a while. There were differences to this financial year in that the allocations were uplifted to reflect the effects of the pandemic, and the NHS received additional money nationally. So that did give us the opportunity to deliver this good financial result. But as I said, we've still had to work very hard to live within our means, and we did so for all 6 of our CCGs. So looking forward now, the next slide talks about our financial strategy, which is very much a system financial strategy. So this is now looking beyond the remit of the CCGs ourselves, but working with our system partners as we do across the whole of Staffordshire and Stoke-on-Trent, to look at how we can really make the local pound go as far as it possibly can. And we expect there to be a financial challenge in the next financial year, which is now 22-23. We're in the middle of 21-22, and in 21-22 we're again on track with our financial targets. But looking ahead into the longer term, we expect there to be some financial challenges ahead, and we've quantified that at about 200 million, which sounds like a huge amount of money. It's actually only 7% of our allocation, and we do believe we can eliminate that deficit and get back to financial balance. And there are a couple of aspects to the challenge that we face. One is that we do have relatively high acute activity for our population. We know that because we compared ourselves with other populations that have a similar mix to our population in terms of demographics. And we do know, unfortunately, that our health outcomes are not as good as some of our peers. So we know that there is room for improvement. But as a system, we've been working now for quite a long time, really, on how to address the financial deficit. And there are really kind of 2 options. And the first option we've perhaps tried in the past and not been so successful with, which is to try and take money out of existing services. And we don't want to do that, and it didn't really work, as evident by the fact that until this last year we had our financial deficits as a system. So the other option which we've developed and have adopted is to use our growth. So as a system, we spend about 2.7 billion, as you've heard. 2 billion we spend as CCGs are. There's other spend within the providers that comes to 2.7 billion. And against that 2.7, we expect to receive growth of about 80 million. So the strategy here is to find ways of not having to spend all of that extra that growth in terms of providing more and more acute services, which we know is not what patients want. We know it's actually not good for outcomes, as demonstrated on the left of this slide, and so we want to find ways of finding better care for our patients through different pathways, and then that way we can then use the growth over a period of time to eliminate the deficit that I mentioned. The solution then is one which is very much focused on clinical performance and putting the clinician at the front of the delivery, and working very closely with our Health and Care Senate, which Rachel Gallio from our CCGs co-chairs, working together between the finance community and our clinicians to come up with a strategy which actually will make healthcare better and provide better outcomes for our patients, and then really use that to drive the financial improvement. And essentially, to live within the strategy that I mentioned of using growth to support the bottom line, what we need to do is find ways of living within the existing capacity that we have. In other words, the existing nurses and doctors that we employ and other professionals that we employ as a system, and really seeing that as a kind of a fixed point and providing care within that those clinical skills, which in any case you'll be aware of the pressures on recruitment of clinical skills. It's very, very difficult to recruit new clinical people, so really retaining our current workforce to provide the care for our patients is what we're going to try and do. And then through that solution, 35 million of the 80 million that I mentioned would be released into the bottom line, and over, we think, about 4 or 5 years we'll get our system back into financial balance. This next slide talks a little bit about the impact of this for a number of dimensions. The first being our system, and what we've agreed as a finance community working with our clinicians is that what we should be doing is asking this very simple question of, does this solution help save the system money? And in the past, as Marcus referred to, we had a situation where different parts of the health system often was arguing with each other. the system allows us the opportunity to work collectively and ask that very simple question of, will this improvement that the clinicians want to make to services, will that actually reduce somewhere in the system a cost, will it reduce costs and provide better healthcare? And if yes, we want to empower our frontline clinical people to be able to make a decision to go ahead. Very simple, but it's something that the move towards the ICS that both Alison and Mark has referred to that allows. In terms of patient care, as I've mentioned, really the focus of our strategy is to say what is the best clinical outcome, because there's evidence of this from international research. The best clinical models result in the best financial outcome. Very simple again, but putting the clinician at the forefront is how we're going to deliver our financial improvement. And within that, in order to not have the increases in acute care that we saw in the past, so in the past we saw an average of 3% more activity in the acute sector. Instead of that, we want to see more and more care provided in the home or close to home. So for our finances, what that means is one simple system bottom line that we work collectively to deliver. And increasingly, not just within the health sector, but working with our partners in social care, and seeing that really as one pot of money that we collectively can spend on healthcare for our residents, our patients within Staffordshire and Stoke-on-Trent. That way we allow the Staffordshire and Stoke-on-Trent pound to go further. So as I say, not a complicated strategy, a simple one, but one that we have widespread agreement to. We have our clinicians on board with delivering this, and we're very confident that building on the success of the current year that we're going to be able to deliver now a sustained period of financial stability for our system, which will be the bedrock to the improvements to clinical care that we want to be making. Thank you. Alison, shall I hand back to you?
Thanks, Paul. So thanks very much. And so I'd now like to move to the part of the agenda where we're going to reflect on COVID-19 and the response through the CCGs. So first of all, I'd like to invite Heather, who's going to update us on the testing programme.
Thanks, Alison, and good afternoon, everybody. I think, as Marcus said earlier, we couldn't have gone through today's AGM without referring to the extensive work that's taken place over the course of the last 18 months while we've managed the COVID pandemic. And I specifically led the development of a testing programme. So a number of things happened, and of course we've done that as part of a system response to COVID, not me, not I, not just me on my own. So as some of you will be aware, the initial expectation was that for people to get tested in the early days of COVID, they would travel over to Edgbaston to the cricket ground and be tested there. And we very, very quickly realised that we needed an efficient local solution so that we were able to manage our own patients at a local level. And quite quickly in that process, we worked with system partners, so with the local authorities and with the other health providers, to find possible sites, and we negotiated sites, and very, very quickly started to get to work on setting up our own local testing programmes. And ultimately what that meant was that before the end of March 2020, so having only been home for a couple of weeks thinking about the impact of the pandemic, we already knew that we were going to be operating testing sites from the Stoke City football ground and from Burton Albion Football Club. And actually we couldn't have done that without the support of those organisations who were unfailing in their continuous support for us to get that moving. And what we did very quickly was we invited CCG clinical colleagues, so nurses and doctors who work in management or other roles in the CCG, but also non-clinical staff who were really, really central to the administration and coordination of this, and colleagues from the army, because we were working with military colleagues at the time. We invited them all to get involved and set these up long before the establishment of the testing programme that we now know and use via the gov.uk link. And just to illustrate the success of that programme, between March and June last year, there were 2,987 requests, which might seem like not a great deal, but in a relatively small area, when you think about the wider country, it's a really big number. And out of those requests, we were able to offer 1,700 tests to people who were eligible, who met the criteria. And of course, what we all know, and we all know that as members of the public, never mind being in the NHS, the criteria for testing and the symptoms and lots of other guidance changed regularly throughout last year. So the 1,700 tests were delivered for people who were eligible, and the remaining people were not eligible under the guidelines at that time. But of course, as the years moved on, that programme has continued to evolve. What that meant was that once we were established, we were able to work very, very closely with the Civil Contingencies Unit and with the Department of Health and Social Care. And we were fortunate enough to be able to establish 2 regional testing sites. So they had to be formally approved by the Department of Health and Social Care, but we had regional testing site status for 2 sites, and then we were able to expand further our testing capacity as the year progressed, so more and more sites appeared in lots of different areas. So we really were able to offer testing to the maximum population that we could. In addition to that, and some of you will have popped along to them and used them, there were mobile testing units which were originally set up by the military but then moved on, and they operated in different parts of Staffordshire and Stoke-on-Trent. Some stayed fixed, but the majority of them were able to move around the area so that they could respond to increasing demand. So if we knew, for example, that the COVID positive numbers had increased in Newcastle-under-Lyme or in Burton-on-Trent, we could make sure we did everything we could to get a mobile testing unit over to one or both of those areas so that we could do targeted testing for our local population. And you can imagine setting that up and doing it in relative isolation required a really organised system for both booking and reporting back tests. And again, working with system partners, and we couldn't have done this without the support of Midlands Partnership, North South combined. Ahead of the gov.uk, we were able to establish that booking and reporting system. What that meant is ultimately that we ended up with a local focus for local staff and patients. So whilst the national system was evolving and being accessed by more and more people, local people could still get tested at a local level. And of course, now we know, because we all do it ourselves, that the work that went on locally has been absorbed into the national approach, and some of those sites are still used for local people to access testing. So it's been a really successful programme, and very early on we were able to say that we were, really, really well prepared to test the local population, and it's considered a real success story. I probably don't need to say any more about that, so I can hand over to Paddy, who's going to move on that journey and take us through to vaccination. So Paddy.
Thanks, Heather. Good afternoon. My name is Dr. Paddy Hannigan. I'm a GP in Stafford. I chair Stafford and Surround CCG, and since the autumn of last year, I've been the clinical lead for the COVID vaccination programme for Staffordshire and Stoke-on-Trent. COVID vaccines, all 3 of the vaccines we use are highly effective. They'll prevent your risk of hospital, or reduce your risk of hospital admission and death by over 90%. It's estimated that the COVID vaccines have prevented about 24 million COVID infections and prevented about 120,000 deaths in the UK. And the national programme has been a tremendous success, and the Staffordshire and Stoke-on-Trent programme has equally been a considerable success. So I'd like to run through a little bit about how we've delivered this, the model of delivery, and how we've used data to drive our delivery. First thing to say is that this is a whole system approach. This is the CCG AGM, but all of our partners in local authorities, all of our health partners, a huge range of volunteers, a huge range of voluntary organisations have taken part in this programme. It's been an entire system response. Within that, the CCGs have had a really central role in the coordination of the programme. We've provided a lot of the manpower behind the scenes to help run the programme. And our GP practices through their PCNs have delivered over 70% of the 1.6 million doses of vaccine that have been given in Staffordshire since the programme began. A truly tremendous piece of work. As Marcus said earlier, our practices have done this on top of their normal activity. Activity levels in general practice are running at about 114% of what they were pre-COVID. So we're even busier than normal, and on top of that, we've been delivering a huge vaccination programme. So I'm really proud of what our practices and what the CCGs have done. Next slide. This is a map of our model of delivery. As I say, 70% of our vaccine has been delivered through our GPs working through their primary care networks across Staffordshire. We've had three vaccination centres, 3 hospital hubs, a number of community pharmacies, and also a roving team which we've used, and Dr. Shami Noor will talk about in a moment. Next slide. We've been very effective. I mean, first dose uptake level across cohorts 1 to 12, which is everybody above 18, is running at just over 86%, and second dose uptake is at 80%. But I apologise, I'm about to blind you with a few more numbers. We've Cannock Chase CCG is currently the 8th highest CCG in the country for first dose delivery across all cohorts 1 to 12. It's also the highest CCG in the country for uptake across cohorts 8, 9, 10, 11, some of the more difficult younger cohorts. North Staff CCG is in the top 10 in the country across cohorts 2 to 7. Stafford and Surrounds is in the top 10 for first dose uptake in cohorts 2, 4, 5 and 6. South East Staffs and Seasons CCG are in the top 10 across cohorts 2, 3 and 4. So we've got some really good local delivery with really high uptakes in several of our CCGs. We've also had about 86% uptake for 2 doses across our learning disability community, 94% uptake in our health and social care staff, and 99% of care home residents have been vaccinated. So really fairly totemic pieces of work around our most vulnerable communities with really good uptake rates. Move to the next slide. Don't really want you to try and look at the detail of this. This is about a methodology. We've used data throughout the programme to drive our uptake rates. This is a table of all of our 23 PCNs across Staffordshire with the cohorts 1 to 12, and we've colour coded them, so red, orange and green, showing uptake levels. And our PCNs have worked really closely with us. They're happy with this methodology. What it's highlighted to us is the areas where we need to put most effort into. And particularly, it's driven our whole inequalities agenda, which we'll talk about next. The methodology we've used across all of our programmes for care homes, for learning disability, for staffing groups, and data saves lives. We've used the data to highlight where we need to work and to put more resources where they're needed. Next slide. We're about to move into phase 3. We've just started this weekend doing the booster vaccination programme. Everybody over 50, everybody over 16 who has an underlying health condition, effectively the same expanded flu group as we were doing last year. We're obviously doing the flu vaccination programme in exactly that same group as well. We have all of our PCNs back involved in phase 3. 1 hospital or 3 hospital hubs, 1 vaccination centre, and a very similar model to phase 1 and phase 2, and we're expecting and confident that we'll get similarly high uptake levels for our booster programme. We're equally working away at other groups. We're offering a 3rd primary dose to our immunosuppressed patients, and our schools programme starting on Monday, delivering COVID vaccination along with the flu vaccination for healthy children in schools. Final area I'd like to talk about is vaccine hesitancy. people make their own decisions around why to be vaccinated. In our high-risk communities, it was fairly clear that vaccination had a really high benefit to you as an individual from preventing hospitalisation and death. As we've dropped through the age cohorts, the individual benefit has reduced, and the wider benefits to society, the people around you, and protecting the whole community has been the main driver for vaccination. We've worked across all of our age cohorts, trying to myth bust, trying to answer people's individual questions. We've used all of our local media outlets. We've had targeted campaigns for pregnancy, fertility, younger age cohorts, a lot of work around ethnic minority groups, and our low uptake sort of geographical areas. We've gone down to the individual level. We're always keen to vaccinate people who have not been vaccinated. And every week, in every cohort, we see people coming forward for the first time for their first dose vaccine. And as we go through phase 3, we will continue to offer that evergreen offer of we can always vaccinate you, even if you've not taken up that offer to this point. So a really big program, probably the biggest thing I've been involved with in my medical career, a really effective program, and we're all, I think, reaping the benefits in terms of the reduction in hospitalisation and the ability for us to get back into normal activity, and for the NHS to get back to the work that it needs to do. I'm going to hand over to Dr. Shami Noor, who's going to talk a little bit more about targeted vaccination.
Good afternoon, thank you. So I'm Dr. Shami Noor. I'm a GP in Lichfield and Burntwood. I'm the chair of South East Staff's CCG, and I've been leading on the equalities part of the vaccination programme. Can I get the next slide, please? So vaccine uptake has been great. It's been really successful across the country, and as Paddy's just said, in Staffordshire in particular. What we did quite early on, I think, in the programme is started to look at the split between the numbers, and found that there was quite a significant difference in the uptake of vaccines across a range of different demographics. So ethnicity, deprivation, and disability were three of the main issues which were giving us very different results. I mean, between the highest uptake group and the lowest uptake group, sometimes it was 80% versus 30%. So I think in a county like ours, where certain ethnic groups are a relative minority, it would have been very easy for that to have just been missed in the headline figure. We didn't do that. We took a deep dive really early on, and we took the ethos that nobody would be left behind. And I think, as Paddy's just said, there has been a degree of hesitancy in different groups, and what we established very quickly was this issue that the message, the messenger, and the mechanism does need to be different for different groups of people. So certain groups of people will need to hear a slightly different message. It might be subtly different, but it does need to be different. We also established very quickly that the messenger is really important as well. That certain groups of people need to feel that they have a trusted member that's delivering that message, and we engage with all sorts of different communities to make sure that we've got those messengers on our side. And then the mechanism, sometimes there was mechanisms which made it difficult for certain groups, certain disabled groups, or certain groups in certain minority areas to actually access those clinics. So the messenger mechanism became a very early ethos that we took. Next slide, please. So we started to engage with community leaders, and in the first instance we went to MOS, to African Caribbean communities. We used our community champions groups, the local authorities. We did radio interviews, and we started off by setting up these pop-up clinics in a few different places, in MOS in particular, and in community centres. And the uptake was absolutely phenomenal, just with a little bit of a change in tact, a little change in the mechanism of delivery, a little change in the way we put the message out. Gave us these really impressive results, and we saw the huge shifts in some of those areas which were lagging behind, catching up with the main group. Next slide, please. So we got a bit of early learning, and we thought, right, this is good, but we need to scale this up. We need to do what we've just done, but almost on a scale which is not going to target just a few places, but actually target all of the inequality across the whole of the county. So we developed this system, this mechanism, this methodology called Identify, Target and Deploy. So we would use our data sets, and on the next slide I'll show you that in a little bit more detail, to look for groups that were being underserved. Okay, so those groups could be split by ethnicity, by deprivation, by postcode, by medical condition, and we had all sorts of different mechanisms by which we could split the data out to make sure that there wasn't any pockets that were being underserved. And we found many of these pockets, and we were able to target them. The next stage was to target. So once we've identified a group of people that are being underserved, we target that area. So that target might be a geographical location. It might be a little pocket in Stoke which is underserved, and we choose a geographical location to set up a pop-up clinic there. Or it might be a certain group. It might be pregnant ladies, and then we'd use a slightly different targeted mechanism to get to that group. And then we would deploy, and in a couple of slides I'll show you our deployment methodology, which involved roving teams, and a massive thank you to the fire service, who were instrumental in producing these teams in MPFT. But this was a really collaborative deployment. So we could identify the problem, we could find a target for where to set up a pop-up, and we could deploy a team, and we just did this over and over again until those gaps were all filled in. And they're not all filled in, and we are still continuing to do this. So next slide, please. So in terms of the identification, I think this was a real win for using all of the data sets and all of the key collaborators involved in health and social care. So the fire service, for example, hold lists of vulnerable people, and we use those. The city and county council were absolutely instrumental in the demographic data that they gave us. We had a lot of vaccine uptake data that, as the vaccine programme progressed, was able to split down into lots of different groups, and as the programme went on, they were able to split it into lots of different categories which weren't available to begin with. And the ethnicity update data that we used as well, and we were able to plug into a lot of the GP data that we hold on a county level. So we wouldn't go into each individual GP practice, but we were able to pull out data sets across the whole county, which gave us this really rich data set of information that allowed us to identify where the problems were. And finally, lots and lots of community teams, homeless teams, nursing teams. There's loads of community assets out there that already knew stuff. So we didn't have to reinvent the wheel. We engaged with them, and they were really happy to engage with us as well. And we were able to identify lots of pockets of missed people. So next slide, please. So once we'd done the identification, we went on to target, and again the willingness of various system players and local businesses and everybody really to want to be involved and want to help was humbling. Really, it was phenomenal. So again, the city and county council offered venues. They offered intelligence on the ground. They knew people that knew the area street by street and could tell us where exactly a pop-up clinic needed to be to get the most impact. We had lots of local businesses and local employers involved, Bet365, etc., who employ lots and lots of people, were offering their services for pop-ups. Local knowledge of local people and community leaders again were used to decide where to put these pop-up centres. and all of our religious and cultural centres as well. And I'll give you a few examples of these on a further slide. So if we could just move on to the next slide, please. So this was our deployment team, and you can see a few pictures here of the fire service and the MPFT teams. So these were teams that literally had an operational meeting twice a week, and we'd have the identification, we'd have the target, and they would deploy, and they would say, right, we'll be there on this date. The comms team would put all the information out, and they would turn up on the day with their mobile teams. And as you can see, that's a picture of a fruit farm in the middle there. They would just turn up, set up the clinic, and just get everybody done there. And it was really, really successful. The picture in the bottom left is a service they had at the mosque in Burton. So the methodology was really successful, and the team have been absolutely brilliant. Really, really happy to do what they were doing, and really well received everywhere they went. Next slide, please. So lots of successes to date. These are just a real few examples. Drayton Manor, Alton Towers, Amazon, TK Maxx, Bet365. We had mosques in Hanley and Burton. Pop-ups at the Hanley Pride event, and local universities and schools, fruit farms, migrant workers, asylum seekers. So all going through that identify, target, deploy methodology. And you know, there were events where not many people got done, but actually, even when we didn't actually physically jab many people, what it did do is it gave that little community, they gave that little subsection of demographics a little bit of confidence, and they then told their friends and they told their family, and we think that had a snowball effect and on other people from that demographic that may not have come forward. Next slide, please. So future plans, we will be continuing with the mobile vaccination programme. Obviously, I think as Paddy said, that the numbers are going down now. We'll also have telephone calls from clinicians to individual patients. Sometimes people just need a personal conversation with their doctor, just to ask questions and feel as though they've been listened to, and we will be supporting local universities and exploring clinics at sixth forms also as the cohort moves into younger people. Next slide, please. And then just finally, these are all the different people, and this isn't extensive by any means, but you can see all the different people that were involved in this. All of our healthcare providers, all of our social care providers, the army in there, the fire service in there, the police service, and they weren't. None of these people played a small part either. They were all really, really, really instrumental in getting us where we are and achieving what we've achieved. But there is one person that I do want to name check, and he is on the call, so apologies for the embarrassment. But Dr. Wahid Abbasi has been absolutely phenomenal in his commitment to this cause. Not only has he been a inspiring and really kind of distributive leader, compassionate leader, but he's actually humbled me with the extent that he's willing to go to. Walk the streets, personally deliver flyers to local businesses and shops. He's been to mosques to do speeches, and I have to say, I think he's personally probably responsible for good old chunk of this, probably more than he realizes. So Wahid, I'm sorry to embarrass you. You didn't know I was going to say this, but just come on the screen and take a bow. Good man. Thank you very much.
Thanks, Shami, and I'll echo that clapping. Don't know how to do it on Teams, so I'll have to do it in real life. Okay, so if we now move on, we're going to spend some time sort of looking forward and look towards as we move towards our 3 place-based partnerships. So I'd like to first of all invite Dr. Gary Free from the southwest of Staffordshire.
I can get the technology to work. Hello everybody, I'm Gary Free, I'm the chair of Cannock Chase CCG, one of the GPs in South Staffordshire or Southwest Staffordshire, and I'm going to talk a little bit about what we've been doing in the Southwest. Next slide, please. A little bit about the Southwest. What is Southwest Staffordshire? It's the 3 or 2.5 actually, because Seaston isn't part of. It is part of Southeast Staffordshire and Seaston Peninsula CCG, which just happens to have the longest name of any CCG in the country. Stafford and surrounds and Cannock Chase. Effectively, what you're looking at for those that don't know those boundaries are South Staffordshire District Council, Cannock Chase District Council, and Stafford Borough Council areas. Within the current white paper that's going through Parliament at the moment, place isn't actually defined as an entity, but there's an expectation that most of the work, most of the decisions will be made at that level, along with what are being called provider collaboratives. That's groups of organisations, that can be trusts, general practice, the third sector, anybody really that is able to deliver the care that people need, coming together to work. Places have been left more or less to, I can say more or less get on with what they need to do to develop. There is some framework, and we are doing some work around place-based partnership development as a system, but how we form ourselves together has been quite individual, I think. For the Southwest, our primary area of focus is around the partnership, and in fact we've always called it a partnership, locality and neighbourhoods. As you may think, if you think about the Southwest, we call it a place, but actually it's quite different whether you're in rural parts of Staffordshire, whether you're in Stafford, Cannock, or down in Seaston towards Wombourne and or Cotswold and Wombourne. So it's quite a different area, and each of those areas could be considered a place as well. So we are in the Southwest are going to focus on 4 main areas. We'll have, and I'm going to say, you can read what's on the screen. I'm going to say it slightly simpler, that effectively organisations, providers working together as with clinicians and healthcare professionals as a team, focusing on our patients, transforming the system, transforming what we do and how we deliver care to align with the system, and there will be a system plan. There are system plans, and that's part of the new architecture for next year, and also our local priorities. Those local priorities, however, we don't just sit there and think, oh, what should we do next? We actually are using data called population health management. It's rather broad term, and it's quite a difficult concept to explain, I think. That means I don't know, but effectively it means using the data to look at where our priorities are, where people need care the most, what are we doing wrong, what are our needs and our demands, and then using and harnessing our other parts of the system. So this is not our statutory organisations, not the likes of Wolverhampton Hospital and Stoke and Midlands Partnership Foundation Trust, but also other parts of the community, our third sector, our voluntary services, some of the other things that our councils particularly supply in terms of things like housing and green space, because they're just as important to health as what we do as clinicians. Next slide, please. So these are our building blocks. It's about integration, change, looking at quality, trying to reduce those inequalities. The outcome should be the same, doesn't matter where you live. And although the Southwest doesn't have such great inequalities as, say, between in North Staffordshire, we still do have those inequalities, and we need to make sure that we reduce those between our residents. As ever, finance and governance always raise their head. It'd be nice just to be able to get on with things and do, but the world we live in is that there is money. We have to consider it. Everybody has to put their money on the table, and so that we can see it, and so that we can work with our providers to deliver the care. And governance, well, that's about being accountable. That's about representing the people that we need to represent, and then actually somebody making sure that we're doing what we're supposed to be doing on behalf of the residents of Staffordshire. Clinical and professional leadership is also very important. We have what's called a clinical health and care assembly, which is groups of health and care professionals coming together to work through the problems that we've identified. That then works with managerial support to ensure delivery. Next slide, please. So we've got quite a few programme areas. Some of these come from our system work, so enhanced primary community care, planned care, urgent care, mental health and learning disabilities. However, we need to develop our partnership, hence we have a place-based partnership development model, a service model, and then some enabling programmes and some extra bits that we're doing, including digital innovation, using technology to ensure that we can deliver better care, that we can ensure that we can help maintain people in their own homes for longer, and children, families and maternity. It's the building block of communities, and without addressing some of the problems that we have in children and families, we will not be able to improve the health of our population in the future. This isn't a short-term goal, this is a long-term thing. Some of the changes that we will need to make will take a lot longer to bed in than just a couple of years. Some of this is intergenerational effectively, but by working together across the southwest, we can ensure that happens. I think that's probably all I want to say for now. So thank you very much for listening. I'll pass on to Dr. Rachel Gallio.
Thanks, Gary. I'm Dr. Rachel Gallio. I'm a GP in East Staffordshire, and I'm chair of East Staff's CCG. I'm just going to give a highlight around some of the work that's been done in South East Staffordshire as a place in place-based partnerships, and looking forward to the work that we're going to do as an integrated care system in the South East. Have the next slide, please. Thank you. So the new approach that we have around integrated care is really involving all parts of people's network. So it's not just health and care, it's education, it's housing, it's their business, it's their businesses, it's their workplaces, all coming together for the health and well-being of that patient. Within the place-based partnership in the South East, we've broadened our relationships with voluntary and community sectors, the housing, education, and looking at people in a holistic view around their health and well-being. And it's vital that going forward that we harness the skills and the expertise that's already in the area to develop that culture of healthy living and supported neighbourhoods. The next slide, please. So a lot of our work in the last 18 months has been born out of seizing some of the positives that have come from a very, very difficult situation with COVID. The opportunity and that's arisen with us all working together, because we've been focused around the work of COVID, where we had to come together very quickly, and really harnessing and understanding that working together across health, social care, with patients, with communities, can bring really good positive results, and they can be results that can be achieved very quickly. So In terms of our place-based delivery, we've aligned the system health and care priorities. We've worked using our health and care assembly, which has got health and care professionals on it, and developed several clinical improvement groups and project delivery teams that have worked with across pathways, so with lots of different people within the health and care professionals and with our local communities to really bring together that vast amount of expertise to work together on several key areas within the South East. The power of this has been shown already, and this is the way that that we are starting to work across the integrated care system. Have the next slide, please. So I'm really proud of the work that's been achieved so far, and under very difficult circumstances at times within the South East, really coming together for that common aim. One of our really early successes was bringing together all people that could be involved within long COVID rehabilitation pathway. And as early as last May, we brought together people in community, primary care, secondary care, and we really started working on that pathway. And we realised that the power and traction we can get while we all sit together and join up existing services and understand how they can work better together. And we saw some really early success from that. Within the South East, we've also had significant improvement in the clinical improvement groups, where we've brought together people on the ophthalmology pathway, and now we've got an enhanced work that's happening in the community, so people are getting the right care in the right place. We've expanded the heart failure pathway. Again, with all these areas within the successes, we've worked with the communities and we've had patient engagement. Indeed, some people on the call have been involved with these, and we've done that with community diabetes and the wound care pathway. So we're really starting to see how working together can really improve things for patients and the people that work within this system to deliver care in a more joined up, integrated way. Looking forward, there's still plenty to do, and there always will be. There's the heart failure phase 2 that we're going to be implementing. There's the respiratory pathway that we've really getting some traction on now to join up all those lots and lots of individual services, but how they should run streamlined together. We've got the community, the CRIS, the community intervention service that's going to be implemented in the South East, and the health communities and compassionate charter development. So lots of successes so far. This way of working is here to stay. It is bringing really positive benefits to patients, and we look forward to doing more of that in the coming months and years ahead. Thank you, and I'm going to hand over now to Lorna Clarkson, North Staffs. Thank you.
Thanks, Rachel. Hi, everyone. My name is Dr. Lorna Clarkson. I'm the Clinical Chair of Stoke-on-Trent CCG, and I'm a GP in Stoke. So I'm going to talk a little bit about the development of the Northern Staffordshire Place-Based Partnership. Next slide, please. The footprint of the Northern Staffordshire Place-Based Partnership basically takes in the footprints of North Staffordshire CCG and Stoke-on-Trent CCG. And we've been working together, providers, patients and the public, the CCGs, our PCN colleagues, our academic colleagues from Keele and Staffordshire universities, to really improve the way that we deliver care and build a strong place-based foundation for our ICS in the North. This is our vision. It's our statement of intent, which sets high ambitions for a new way of working, which places the citizen, our patients and service users, absolutely at the heart of our services. Next slide, please. We feel a really strong sense of shared purpose, and that is to develop truly integrated models of care, to bring renewed leadership and focus to improving outcomes for our communities, with place as the essential building block on which we develop our plans. The important bits of the shared purpose that you'll see on the slide for me are encompassed in that very first bullet point. So we care about the people of Staffordshire and Stoke-on-Trent. They are close to our hearts. To many of us, including myself, they are our friends, our relatives, and the people that we've grown up with. So this is an important opportunity by which we drive forward actually measurable improvements in health outcomes, tackling health inequalities, and sustainable use of health and social care resource. We absolutely want our partnership to be inclusive, and we want to make the best use of our really talented workforce to create integrated services and leave a legacy of sustainable improvement. Next slide, please. So you'll see in the diagram who we are. We are a very varied and diverse group from the voluntary sector, patients, the public, academia, providers, primary and secondary care, community services, mental health, as well as the CCGs and importantly our local authorities. We are lucky enough to have 2 local authorities engaged with our place-based partnership, both Stoke-on-Trent City Council and Staffordshire County Council, and we have great engagement from both of them. I think this is because we all recognise that this must herald a different way of working. As much as we would like to think otherwise, it is well recognised that whatever we do in terms of delivery of health services, it only has about a 20% impact on people's actual health outcomes. So if we focus purely on what we're interested in health, and we neglect those wider social determinants, those behavioural, economic, employment and education facets of people's lives, we absolutely miss an 80% opportunity to influence how well people can live and their outcomes. And we are absolutely committed to changing to do that. We recognise that success will be built on these partnerships, but not only with each other, with communities, citizens and patients and service users with lived experience, and also as part of the wider health and care system that continues to experience significant challenges in responding to what are often deep-rooted health inequalities in a clinically and financially sustainable way. So although PLACE is our essential building block and it's absolutely important to look inward, we absolutely need to look outward to dovetail into that wider ICS. Next slide, please. So this is a slightly complex slide, but what essentially this is saying is that the way that some NHS functions are arranged is likely to change from April 2022. And this will have a bearing on the way that we design our place-based partnership. Initial analysis suggests that the functions that you see in blue could be delivered through our place-based partnership, and those are the sorts of things that we're preparing to do. Things like place-based planning, integrated pathway design, and clinical and professional and public and community engagement. We need to do more work to arrive at a system collective agreement on the exact scale and nature of what the place-based partnerships will be asked to do, and that'll enable us to agree the final form that our place-based partnership will take. Next slide, please. So our priorities. It would be absolutely incredible if we didn't start off with our main priority being the restoration and recovery of services after the COVID-19 pandemic. We aren't all the way through it yet. There is still a lot to do, and we need to collaborate to restore services to meet the needs of our population. We need to work hard so that patients aren't having to endure such long waiting times, but we recognise that this is going to take some time. Another priority is that we must provide better, more integrated care. And the clinical areas that we've been focusing around are quite similar to those that Rachel described in the South East. So they're focused around care for the frail elderly, for those with long-term conditions, improving access to mental health services, improving health and care services for children and young people, as well as implementation of the long COVID pathways. Our priority also has to be to do this in a different way, so driven by population health management, which starts from meeting the needs of the population and coordinating care around the person and not our organisations. It looks to design targeted services which are evidence-based and deliver best practice. And we absolutely must make sure that all of our pathways and all the services our patients receive are based in this approach. We are focused on reducing health inequalities and improving outcomes through prevention, early intervention, and empowering citizens and patients to live well. And the flagship of our different way of working is our community asset-based approach. So understanding and identifying what community assets are already out there, and building on that, empowering citizens to identify opportunities to improve services and engaging them in the way that we tackle community support, as well as providing health and care. And then the final priority is fully establishing our clinical and professional assembly. This is a strong network of local clinicians and professionals from across all kinds of different disciplines that we've built, who are empowered to use their expertise to identify and solve problems in local health and care delivery, as well as support one another and make sure that we are all playing as part of the same team, and that is protecting the interests of our patients and the public. I'll thank you very much for listening, and I'll hand over.
Thank you, Lorna, and thank you to all the presenters today. That's been great and a really comprehensive review of what we've been up to over the last 12 months. So it's now time to open up the meeting to your questions, and I'm going to be joined by the whole of the executive team and the clinical chairs to answer your questions. So during the question and answer session, could I ask that you raise your hand to ask a question, and then when addressed to be invited in, unmute your microphone, and if you'd like to be seen on camera, you could also turn your video on. And also, if you could state your name and, where applicable, the organisation that you are from, so that our interpreters can correctly represent what's being said. So we did ask for questions ahead of the to be sent in ahead of the AGM, and we did receive 2 questions from Mrs. Julia Carter, who wasn't going to be with us, but I'm glad to see that she's actually been able to join the meeting. So Julia, could I ask you to present your 2 questions, please, and then I'm going to ask Craig Porter, who's our Managing Director from the South West, and Heather Johnson to respond.
Hi, yes, thank you for the opportunity to do this. Assurances were given to the chair of the CCG following a review of commissioning procedures for the reprocurement of autism services, that parent care engagement was taking place via the South Staffordshire Autism Partnership Group. No partnership meeting has taken place for almost 12 months. How can you give assurance to your chair and not see that through? If the CCG have closed the partnership for an alternative route of service user participation, why have the original members of the partnership not been informed and invited to the alternative group? So that's my first question. I don't know whether you want to answer that and I'll come back with my second, or...
Craig, do you want to respond to that first?
Yeah, thanks, Alison. And hello, Julia. For colleagues who don't know me, I'm Craig Porter. I'm the Managing Director of the Southwest Division of the CCGs. So I recognise, Julie, that since our meeting in October 2020, collectively we've developed some new joint working structures with our system partners, service users and carers, to support the delivery of the jointly agreed all-age autism strategy, which was signed off towards the back end of last year. We believe, therefore, that the original remit of the SSAPG, which was implemented following the Northumberland Tyne and Wear report, has now been superseded and we believe strengthened, most notably the Autism Local Implementation Board and the SEND Staffordshire Parent and Carer Forum. So given these new working structures, and now we've fully mobilised the new South Staffordshire Autism Service delivered by our colleagues at Midlands Partnership Foundation Trust, we do now believe we can move forward and formally stand down the SSAPG. And on a personal note, we are enormously grateful to the commitment of SSAPG members in supporting us on our service improvement journey over the past 12 to 18 months. Of course, we'll continue to listen to and work with our partners to listen to feedback and co-produce future services, most notably and recently that's included the Key Worker programme, which is just about to start with the Midlands Partnership Trust, and obviously any new partnership arrangements as we move forward. I think I absolutely recognise the significant work the team at MPFT have undertaken, not just through COVID, and continue to do so, to listen and engage with service users and families. Specifically, I welcome their ongoing programme called Talking Together for Change programme, which I understand has been well received by autism groups, parents and carers. Obviously, from a CCG perspective, we're always happy to receive any feedback on commission services as we move forward with the implementation of the new strategy, so that we can continuously improve our services for the local population. Thank you.
Could I come back on that, please? Out of courtesy,
yes.
Do you not think you should have informed the members that gave up their valued time formally, including committee members of the National Autistic Society, Health Watch, and members of significant groups across our autism community? We've been left hanging, and an assurance to your chair has been left hanging. And also, we haven't been invited to join any of this new group or forums that you've set up. Why?
So, Julia, obviously we've been waiting for the new service to mobilise, and I hadn't formally stood down the SSAPG, but we will now take that opportunity to communicate with partners. In relation to the new structures, if you believe, and the group that support you believe, there isn't sufficient or adequate carer, people with lived experience and users' voice within those new structures, I will of course take that up with the chairs of those two groups and see what can be done.
Thank you. I'd very much like to be invited to that. Should I go on to my second question?
Yes, please, Julie, if you could give your second question.
Okay. Given the recent publicity, media and publications by prominent figures within law and education around parental blame, how is the CCG tackling its own evidenced failings in understanding the very difficult pathway parents face when advocating for their child? How are you safeguarding disabled children and parents from accusations of fabricated illness by health services and unnecessary referrals by them and the CCG to social care safeguarding teams? What training in hidden disabilities have the CCG staff had, given we were assured that would take place by the accountable officer?
Thank you, Julian. Can I invite Heather in to respond to that, please?
Thanks, Alison, and thank you, Julia, for raising this really important question. Historically, as you rightly point out, there was criticism of predecessor CCGs in respect of their management of these difficult pathways. And as you know, since the current CCG started working together, we've made a conscious effort to ensure that historical matters do not reoccur. In respect of your second point, I'm sorry to say there's no such thing as an inappropriate safeguarding referral. And in fact, professionals have a duty to report any concerns they have, which may sometimes include reference to fabricated and induced illness. In respect of the last part about training in hidden disabilities, beg your pardon, as we agreed we would probably about 12-18 months ago, we have introduced a programme of hidden disabilities training, and all staff have now undertaken that training, which is now part of the mandatory training programme. In a further extension of that, we've introduced unconscious bias training to ensure that all staff have a good understanding and awareness of all of these important matters, and new staff coming into the CCG will be expected to undertake that training as well. So hopefully that answers your question.
Can I just very quickly come back? In terms of failings around unnecessary referrals based on no evidence, that is not historical. That actually happened under this CCG's watch. Thank you, Heather, though, for your comments.
Thanks, Julia.
Thank you, Heather. So I'll now take some questions from the audience with hands up. So if I could turn first of all to Derek Hoey, and again, if you could just introduce yourself and say where you're from. Thank you.
Good afternoon. Thank you, Alison. Yes, my name's Derek Hoey. Amongst other things, I'm chair of the South East Staffordshire District Patient Group. Just like to ask a couple of questions of Marcus, if I may. In relation to the session that you gave us on achievement, I thought that was really interesting. The Community Rapid Intervention Service, CRIS. By coincidence, I was sat around a table just a few days ago with some people with likewise positions to mine, involved fairly regularly in the health service, and someone said, "Anyone heard of CRIS?" And we all looked at each other and shook our heads. So none of us were aware of it. So I think that there's an awareness situation there. But my question in relation to this is, how do I access CRIS? Do I dial 999? Do I dial 111? Do I see my GP? How am I recognised as a patient who needs that service? How do I qualify for CRIS? And secondly, just moving on to NHS 111 first, which I think potentially is a brilliant service, which has been going for a little time now. I think one of the great advantages of that potentially is getting the pre-booked time slots in ED. But as is often the case for those of us in the southeast of the county, for those of us who might be blue lighted to Good Hope, for example, that doesn't work because that pre-booked facility doesn't work across borders into UHB, which is worrying for patients in this part of the county. So I wonder if you could address how that might be addressed.
Thank you, Derek. I'm actually going to invite Cheryl Hardesty in to respond to the question, particularly around CRIS. Over to you, Cheryl.
Yes, hello there. I'm Cheryl Hardesty. I'm the Executive Director for Commissioning and Operations. And thanks for the question. And I'm really glad you raised it about CRIS because it really is an achievement for us. And I'm sorry that you didn't know what it was. It's still fairly new in the scheme of things. It is up and running well, particularly in the north of the county. It is a centre that's a call centre, if you like, that's managed by UH&M, but working in partnership with our community providers and GPs and others. In terms of it operating across other areas, we're looking now at the southwest, where we're almost ready to go, and in the southeast certainly we're expecting something to happen in October. Just in terms of what CRIS does and how it's accessed, it is a response to a mandated service around a 2-hour response time as part of the urgent care programmes of work. And this is a service that can be accessed by GPs, social care, particularly by the West Midlands Ambulance Service. And in essence, this is about the team then being able to have a virtual ward, if you like, around supporting people to stay in their own homes rather than be conveyed into A&E. Or is about the ability to have a virtual ward around pulse oximetry, for instance. That means that people do not need to be conveyed. That's the basics of it, and it's a real alternative to patients going into A&E. It's had a bit of a slow start, but do you know what? Today it's up to over 80 referrals a day. And patients are benefiting all of the time from that. I don't know if there's anything else I can tell you about that. Is there anything I've missed for you?
So if I understand, so the patient might dial 999, for example,
yeah,
but would then be allocated a CRIS response.
Not necessarily. So it's certain categories. So
that might be,
yeah. So if there's
Sorry, Cheryl, I was going to say, Nikki was wondering about coming in about bringing it to the patient board. So so could I just invite Nikki in?
Thanks, Alison. I'm Nikki Harkness. I'm Managing Director for the South East locality. Hi, Derek. I think probably what would be really helpful, because we are about ready to launch CRIS in the South East, is if we dedicate a bit of time at our next patient board to go through it in detail, if that's okay.
Yeah.
And I think then what we can do there is probably pick up some more of your questions around the actual pathway, and also agree how we can disseminate some of the information out through the PPG groups about what it's going to do and the success that they've had in the north in introducing the service. Is that okay?
Yeah, great.
Thank you.
Thank you, Nikki, and thank you for your question, Derek. So if I could now bring Ian in, and if you could come and give your questions, please, Ian.
Right. Thank you for an interesting AGM. I was particularly interested in the PBPs and heartened by them. Basically, I think the aspirations are wonderful, but aspirations don't necessarily deliver what the aspirations say they are going to deliver. I've got two questions on transition and one question on maternity, Chairman. The CCGs have formal, strong lay representation. I'm confused how there'll be formal, strong lay representation that understand locality, understand engaging with locality, which was obviously very important in Shami's presentation with regard to vaccination, how important that is in involving and getting trust with local locality, how this will pan out in the future. Could that be clarified, please?
Ian, do you want to do your second question on transition, and then we'll try and deal with both of them together, respond?
Right, ICS, the whole system about an integrated system, I understand it's medium to long term as well, certain aspects. It's fostering collaborative working and cooperation. It's predicated on certain things, one of which would be the extra 5,000 GPs that were promised. I think it's in the long-term plan, which are very unlikely to be delivered, and other things. Now, what I'm confused about and quite frankly a little bit worried about is, as the agenda, certainly for the foreseeable future, is going to be, and it'll be a political agenda, and I'll get louder and louder, addressing very long waiting lists, how are you going to ensure during transition the successor bodies will still be holding the priority ring on integration, because resources, we know that international recruitment and staffing has stalled. Resources are likely to be more and more concentrated, and energies of different care systems will be concentrated on addressing, admittedly, it has to be addressed, the long waiting lists.
Thanks, Ian. So I'm going to first of all ask Sally Young to respond to the first question around lay representation. Sally? Here she is.
I am here. I've just had a few problems with my internet. Yeah, good question, Ian, that one is. So just to sort of give you a bit of additional information about this, the guidance refers to there being two independent non-exec directors on the ICS board, and local and systems can decide themselves if they want to have more than that. So those are the independent non-exec directors. The point you're making about how our lay members have been good local and within each CCG sources of information and advocates, etc., and have really held to account over the years is a good one. We are doing some work with David Pearson, who was the chair of the STP previously, to look at how we can get a really strong engagement system in place. And it is pretty obvious, I think, to all concerned, certainly to our lay members when I've spoken to them about it, that we really need to build in proper engagement routes through our local areas. So we're going to build on that and take that one forward. So we'll haven't got it all sorted yet, but as soon as we have, we'll make sure we'll share that information with people. And just so everybody knows, the 2 independent non-exec roles are due to be advertised nationally on October the 4th. There's going to be a national advert for all 42 ICS systems. So.
Thanks, Sally. And so could I, Marcus, could you come to respond to Ian's second part of the question? I know you've been having technical issues. So Ian, do you need Ian to just very quickly summarise his question?
Yeah, my apologies, Ian. I've been sort of in and out a little bit and I missed some of your second question. Would you mind just asking it again, please?
Yeah, it's basically, you know, the integrated care systems of fostering collaborative working, cooperation, etc. It's predicated on obviously staffing. You've got significant problems in staffing recruiting at this moment in time. 5,000 GPs key in integrated care, 5,000 extra. It's likely that won't be attained nationally. And of course, you've got in the very short term, the political emphasis is most certainly going to be on long waits for acute care. Now, how are you going to ensure that you carry on holding the ring and it becomes you become powerful advocates in the transition period for integrated care, and don't, because resources are going to pass, greater and greater amount of resources, not just money, it'll be energy and time will be passed to trying to address that massive waiting list that's built up over COVID. And also, you know, you've got things like mental health. You mentioned parity of mental health. That could fall off the agenda. How are you going to ensure that gets passed on and is held by successor bodies?
Thanks, Ian. There's quite a lot in there, really. I think our key problem, as I said in my presentation, is workforce. We have huge problems around workforce, and it's not just a local issue, it's a national issue. The 5,000 extra GPs, I think we're about 2/3 of the way towards that. So Lynn's got the exact numbers, but we're not where we need to be nationally in terms of GP recruitment, and I don't think it's a news to anyone that attracting young clinicians into general practice as a career option has been a challenge for some time. And part of what we learned through COVID is a different model of providing general practice, less reliant upon GPs, more about a team approach where people can see nurses, allied health professionals, pharmacists is going to be absolutely key. So yes, general practice is workforce is a challenge for us. The issue around elective waits, clearly managing the business as usual. I think there's about 8 million people on waiting lists at the moment. Being able to actually do the waiting list, which is not a backlog, it's people waiting for care, ensuring those people get their care they need on top of managing demand as it comes through, is going to be a real challenge for us. And not made easier by the fact that people have been working really hard during the pandemic and are burnt out and are tired. Things like the pension tax changes, etc., don't help. So it is going to be a real challenge for us, Ian. And I'm sorry, I don't have an answer to the workforce challenge that I can give you now that will give you all the assurance you need that we're going to be able to make the progress that we need. There is a lot of money, obviously, is being thrown at the problem. Second half of the year, about 5.4 billion made available to the NHS. But you can have all the money in the world if the people are not there to pay to deliver the care. You know, that's going to be a problem for us. So it's a challenge for our system, for all other systems. We're doing everything that we can across the system, working with regional colleagues and national colleagues to try and come up with solutions to that. It's a really good question, and it's something that is vexing us all at the moment, and will be a key plank of our restoration and recovery approach. But Ian, my apologies, I can't give you ultimate assurance that we're going to be able to solve that anytime soon, but it's clearly something as a system we're very much working on.
Alison, if I could quickly just come back on that, and then I can go on to the maternity.
Yes, very quickly.
Yeah, could I suggest that visibility of the integrated approach isn't in any way diluted or abandoned? You have to be in the eye of the public all the time.
Yes, I mean, just in terms of the, I think there was the mental health element to your question as well, and parity of esteem. So it's not just about elective waiting lists, not just about urgent care, but how can we ensure we continue to make the investments in improving mental health services, learning disability services, etc. That has been a real priority for us, and I think probably fair to say some of the best performing parts of the system at the moment are mental health and learning disability services. And as I said in my presentation, as Paul confirmed, we have actually continued to increase our investment in mental health and learning disability services, and we work very closely with both local authorities as well through our Section 117 arrangements around increasing investment in those areas of care. So to some extent they've been less of a priority some years ago. They're very much at the top of the list of priorities now. And I think, as you've probably heard through the various presentations, we are very keen that parity of esteem is something that we'll maintain as we come out of COVID. And it's not just about elective waiting lists, not just about urgent care, but we continue to provide the focus that we have been on providing reducing waiting times for mental health and LD services, and providing excellent levels of care for those very vulnerable groups of people who need our support.
Thank you, Marcus.
Thank you. And if you could do your last question, yes, please.
Right, I'll be as quick as I possibly can. There's been a recent CQC review, safety, equity, and engagement in maternity, and it can make for quite some. I know it's national, but it can make for some disturbing reading, especially with the services that the BAME women get and the risks they are put under. I don't like the term BAME because it assumes that ethnicity and such is homogenous. Then, of course, it isn't. It's heterogeneous. But BAME women, especially black women, women of mixed race, are more likely to be readmitted postpartum. They're more likely to die. The children are more likely to die than the white population. Now, I know that the CQC review also stated that maternity voice partnerships, the relationships with providers and commissioners is very patchy nationally, that the maternity voice partnerships have a huge amount to offer and are sometimes ignored by trusts, as trusts seem to prioritise other things. Now, how are you going to maintain, rather similar to the last question, a concentration and understanding the priority of maternity services, especially amongst BAME communities that do suffer disproportionately adverse effects of maternity services, whilst at the same time juggling other priorities?
Thank you, Ian. So could I invite Heather to respond to that, please?
Yeah, thanks, Alison, and thanks, Ian. And again, a really, really good question. Quite a lot in there, and probably one we might need another conversation about. But I think just in terms of giving you the immediate assurance, I think probably one of the most important points links to the previous conversation about workforce, really. And as I'm sure you're aware, CCG staff sub-board level have an employment guarantee that sees them through into the new organisation. And what we've done recently within the CCG is make some members of our previously temporary staff who work on maternity permanent members of the team. What that means is that they will transition into the new world along with everybody else in the CCG that transitions, to ensure that we have and can maintain that period of stability. Now, included within that, and they work in my team and under me, is a lead midwife for maternity, 2 quality and safety midwives who, as you rightly point out, as you might imagine, will be picking up the issues that the CQC have highlighted, and that the Ockenden review into South highlighted, and her next report will no doubt underline, but also includes our Maternity Voices champion lead, who works very, very closely, and I have to say, locally, exceptionally well with all of our providers and our parents on the MVP agenda. Now, in terms of the, and I'll use your phrase, the BAME group, what we've done this year already is a number of engagement events around maternity services, and we have tried to target some certain hard to hit population groups. and we'll continue to do that. And I know certainly I've had a conversation with Wahid Abbasi, who you all met earlier, about how we might do some more specific work and maybe some visits to make sure that we're doing everything we possibly can to support those hard to reach groups, or the ones where there is a higher risk when ladies are pregnant, giving birth, and in the immediate postnatal period. So I hope that provides some degree of assurance. But Ian, if you want to discuss further, always happy to have another conversation.
Thank you, Heather. So thank you, Ian, for all your questions, and I'll take the final question now from Sue Rankin.
Hello everybody, thank you very much. I've enjoyed the AGM so far. I was at a health and care overview web meeting on Monday when the question of urgent and emergency care came up, and I was pleased to see the letter that came out from Marcus. But one area I may have got wrong and read it incorrectly, but I see this is going to be GP led. With more services being GP led, I wonder when GPs are going to find time to see patients within their practice. We've already got, my phone is red hot with people ringing up saying they can't get appointments. If all these GPs are going to lead these new hubs and various things, where are they coming from? Thank you.
Okay, thank you, Sue. Who would like to respond to that question? Is it Cheryl or Marcus?
Could I suggest Lynn, if Lynn's on, Alison?
Yep, Lynn. There you go, Lynn.
Somebody's got to have the short straw.
That's right. Hi, Sue, and thanks for your question. I mean, it is a really real question. You've probably seen in the chat that I've said, compared to 2016, when we were promised an additional 5,000 GPs, we're now nationally 1,300 fewer than we were 5 years ago. So it is a very real problem. I think in terms of the GP-led sort of phrase, what our PCNs are doing, our primary care networks, is providing that leadership role. So yes, there is a problem in GP gaining appointments in GP surgeries. We have introduced a new workforce, and we've in Staffordshire alone we've appointed 250 whole-time equivalents, advanced nurse practitioners, physios, prescribing pharmacists to actually support the workforce. I think what we haven't done very well is promote that, and nationally it's not really been on the agenda. But actually you might not be able to get an appointment with your GP, but you could see another health professional. So I think we've got a bit of a work to do about the whole multidisciplinary team in general practice. But in terms of the GP-led urgent care offer, I think what we're looking at is a leadership role for general practice and GPs. So we've established 25 primary care networks across Staffordshire. Each network has a clinical director who's a GP who has that leadership role. We also have GP federations that are led by GPs, but also use that MDT, the multidisciplinary team, to provide services. So I think when we talk about the GP-led services as part of your original question, there's a leadership role there, but actually it's going to involve a wider multidisciplinary team to be able to deliver the services. What we need to do is give confidence to the public that actually they will get a good service from a physio who might be best placed to care for their needs rather than a GP. A prescribing pharmacist might have more expertise in terms of medication reviews, for example. So I think we've got a bit of work to do about communication on this one, actually. So because over the last 18 months, general practice has transformed itself. We've not necessarily told people how it's changed, and I think that's probably the next step, really.
Thank you.
Can I ask a quick second question?
Very quickly, because we are.
It will be very quick because I can see the time. I was pleased to hear Marcus say that communication was much better for CCGs, and by having these sort of social Zoom team meetings. But what about patients? Patients are still struggling to get communications from CCGs, and I'd like to see them by this time next year be able to say communication is much better for patients. Thank you, and I finished.
Thank you, Sue. Does anybody from the communications team like to just respond to Sue's last point? Jenny.
Hi, Sue. I'm more than happy. So I'm Jenny Fullard. I'm communications and engagement team. I'm more than happy, Sue, to have a conversation to hear your ideas for how we can improve communications. We're working really, really hard, as Marcus said earlier in the presentation, to try and reach as many people and make sure that they're informed and involved through the range of different programmes we've got going on at the moment, both at a CCG's level and the integrated care system. So I'll get in touch after this call and hear some of your suggestions.
Thank you, Jenny. Okay, so thank you everybody for those really interesting questions, and any comments that have been put in the chat or questions, we will respond to those after the close of the meeting. And Tanisha has put a link in for any further questions as well that we haven't had time to address today. So I'd like to bring, just before as we come to the end of the AGM, I'd just like to invite Marcus in to say a couple of words just to before I close the meeting. So Marcus, could I just ask you to come back in?
Yeah, no, thanks, Alison, and I'm conscious we're slightly over, so I'll keep it brief. I think the first thing to say is thank you everyone for joining us. We've got, I think, some pretty good attendance on this AGM. And having sort of been all over Staffordshire in previous years doing AGMs, hopefully the fact that we're doing this through Teams, we're doing it once, so you can hear from all of us, for the members of the public who've joined us. Hopefully you've found that a good alternative to the way we normally do these things. So we'll draft the evenings in village halls and hotels and stuff, doing it over Teams from the comfort of your own home. Hopefully you found that helpful. We've covered a lot of ground today, and yeah, much of the focus from last year was very much on COVID. And just another huge thank you to all of our team, for everyone across the system, for I think managing as best we can through an incredibly challenging time. I've said it before, in my 31 years in the NHS, it's the most difficult year I've been through, and we've had to very, very quickly adapt to a very different way of doing business and working. Just a thank you to all of our team, all of our GPs out there who, in most cases, have borne the brunt of the pandemic, because that's often the first place that patients go to when they need help and support. Thank you for that. Thank you for the team that pulled the seminar together, our comms and engagement team. Thank you to our British Sign Language interpreters, who I have to say, given the material that you've been trying to interpret for our hearing impaired audience, I think you've done a sterling job around that, and hopefully we didn't make your job too difficult for you. This is the last year of the CCGs. I don't know whether we'll be having another AGM next year about the issue. I'm not quite sure how that will work. But if this is our last AGM, we've been here for 10 years or so. Thank you particularly for the likes of Ian Simon and other patient voices out there. Thank you for bearing with us. I think we've had our ups and downs. I think, generally speaking, I think it's been a successful 10 years or so. And well, hopefully you'll miss us when we're gone. But thank you for joining us, and I'll hand back to Alison.
Thank you, Marcus. So just some closing remarks. As we said at the beginning, the event's been recorded, and so it'll be available for you to view again on all 6 of our CCG websites within the next 24 hours. And you can also provide us with some feedback via the evaluation survey, which is now, the link is now in the chat that Tanisha's put in there. And for all of you who are registered to attend today, you will receive an email which again has the evaluation survey in, so it would be great if you could complete that. And also, don't forget, you can follow us on all our latest updates on social media, Twitter, Facebook, Instagram, and even YouTube. So we are getting out there. Okay, so thank you everybody. Thank you everybody for joining, and everybody who's supported the event, as Marcus says, and all the presenters. And have a wonderful evening. Bye then.
Thanks everyone. Bye now.